Today's episode is sponsored by Gago Fertility. Gago Fertility is a lovely female-led practice based in Michigan, and they offer every type of service and a lot of hand-holding. They offer IVF, IUI, donor conception, all sorts of treatment, and now surrogacy, since Michigan is now legal for surrogacy, and you will hear all about it in this episode. Have you ever wondered why surrogates have such extensive workups, so much more than if a woman was going through natural pregnancy? Have you ever wondered why surrogates can be older than donors? Well, these questions and more are going to be answered today by Dr. April Gago, who's going to give you a wealth of information about things that lots of people wonder about. So check it out. I think you'll find it really interesting. Welcome to Building Your Family. This is a podcast about fertility treatment, surrogacy, donor conception, and all the ways the modern family is built. My name is Lisa Schumann. I'm your host. I'm a therapist, a researcher, and the host of this podcast. And I'm so excited today to introduce you to April Gago, who is a fantastic reproductive endocrinologist and fertility specialist who runs a practice in Michigan and several practices, actually. She's a fantastic doctor, but also a lovely person. I met her through one of her employees who raves about her. And you know, if employees are raving about you, then you're really special. And she's also really coming to us in this wonderful time because her state has just changed their surrogacy laws. So I'm going to introduce you to her now, and we'll hear a little bit about the surrogacy laws, a little bit about surrogacy, and the things that will be important for you to know if you pursue surrogacy or using a gestational carrier, and also for IVF treatment in general. So welcome, April. So happy to see you, Dr. Gago.
Thank you, Lisa. Thanks so much for the nice introduction. And I have to give a shout out to Mary Vitsky, who is a tremendous IVF nurse and supports our practice day in and day out. And she's, really passionate. So we have Gago Center for Fertility with our IVF lab in Brighton, Michigan, with offices in Ann Arbor and Lansing. And we really, are in Michigan. A lot of our practices serve, the entire state in the area, especially because prior to this new bill, which we are tremendously excited about, I think I have to say that we have a lot of female leadership at our state with Governor Whitmer and several other top leaders in our state are women, which has been a fantastic advantage for us. And we've been able to move forward because people have been fighting for more than a decade to get improved laws in our state for gestational carriers and surrogacy, and they managed to accomplish it pretty readily in the last year, which has been fantastic.
It's amazing.
Yeah, I just was refreshing the information, and because it did not pass with a 2/3 vote, we're going to have to wait for it to be enacted until 90 days after they complete their session this year. So we're still in the waiting period, but it's wonderful news for families throughout Michigan. Before this, we were able to do gestational carriers and surrogacy, but it was very tricky and very delicate. And some families ended up having to actually go through full legal adoption process of their own children, which was agonizing. And there are some big cases that were in the news that happened during COVID. And as we all know, it was very limited. And so if your baby was in the hospital during COVID and you weren't considered the parent, you weren't allowed into the hospital to be with them. So it created a lot of problems. So we're really looking forward to the changes.
That's great. Well, it's finally here, and we had the same issue in New York. We had to wait a long time in a state where I grew up, and I thought everything was so progressive. It really isn't, and there's a lot of different opinions about surrogacy. But it's so important to understand compensated surrogacy, and the people who are surrogates are such wonderful people, really trying to help other families who, for infertility reasons or same-sex couples, really are not able to get pregnant on their own. So it's so fantastic that you're able to serve this population now.
Yeah, it is wonderful. It is. And as you know, there are numerous reasons, as you alluded to, women who were born with abnormalities where they didn't have a uterus or they didn't have a functional uterus, women who've had a pregnancy or two pregnancies where there were serious medical complications, where it's either completely impossible to be pregnant again, or it would be life-threatening for that woman to try to carry another pregnancy with very serious consequences. And then also same-sex couples, so there's this wide range of patients that need that kind of help to build a family. It's going to be very nice because for the last 18 years that I've been in practice in Michigan, we've had to send people, many people have gone out of state to avoid the risk. So many people, and it went to, Indiana, Ohio, Florida, California, New York, different places to pursue surrogacy.
Yeah. So while we're on the topic, I thought it would be good to answer some people's questions about surrogacy or using a gestational carrier because there are a lot of misunderstandings around this topic, I think. For example, I think one of the things that people talk to me about a lot is they don't really understand why it's so important to use a gestational carrier who's approved by their physician, whose uterine lining is in good shape, that their BMI is in a good place, that they have a healthy lifestyle, and that they're otherwise prepared to carry and deliver a child.
One of the several nice things about our new law is it is included in the law that the
Oh,
carrier must have both mental health and a reproductive endocrinologist medical evaluation and
great.
approval prior to moving forward. So I think there are several things built into the law to
Mhm.
protect the carriers as well as the intended parents. And as we always lamented that we were the last state to get a better law, but the advantage of that, as one of the lawmakers pointed out, is they were able to look at all the other laws in the country and take the best elements from all of those laws and craft a very modern version, which will be an advantage moving forward for those of us in Michigan.
That's great.
Yeah, but to your point about the medical issues, so what we're doing is we're taking couples and individuals that are unable to carry a pregnancy themselves, and then they're spending a lot of emotion, a lot of time, and a lot of money and resources, and they're asking a lot of the carrier as well. And we want to make sure that we're giving it the very best chance for success. We also want to make sure that we're minimizing the risk and harm to the carrier
Hmm.
and the fetuses and the babies that will be carried. And so the health of the carrier is extremely important. And so younger age, not having too many prior pregnancies, not having we just had a survey in our REI group. How many cesarean sections will you allow in a carrier? And that becomes a real issue because of the more cesarean deliveries there are, the increasing risk for abnormal placentation, which significantly increases the risk in the pregnancy to both the carrier and the babies. So those are important issues that we look at. Unfortunately, increased BMI does decrease success rates, and it does increase the risk for the carrier and the babies, with increased risk for particularly diabetes, but also preeclampsia.
So that's really important, I think, for people to understand because very often they say, well, there's lots of women who have a large BMI number and they get pregnant. And so why can't my carrier do it? But it's not necessarily the healthiest thing.
Right. And they may be successful and they may do fine, but you're increasing the risk of something going wrong. And when you're going through this process, it makes sense to try to make it as safe as possible for everyone involved. And that's why it's good that there are some requirements of physicians being involved when there are embryos being transferred.
So, can you take us through what the screening process looks like from the medical standpoint?
Sure. I usually start, Lisa, with the mental health component because I
Hmm.
think that is the first stop to kind of make sure that first we have the intended parents meet with a reproductive counselor, a mental health professional in this area to make sure that they've really had a good discussion between the two of them, if there are two parties, and that they're on the same page and that they've thought about all the things, and you know better than I do
Hmm.
that. And then we start with the medical. I go through their history again. their history of pregnancies, their health history, any cardiac, pulmonary issues, any significant health issues, autoimmune disorders that would make them a poor candidate to be a gestational carrier. We also then would do a physical evaluation, or we would also, of course, as I talked before, their pregnancy history. Did they have successful, healthy, low risk pregnancies themselves? And we don't like to use carriers if they haven't had a pregnancy already for
Hmm.
many reasons, some of which would be mental health. They don't, and also they don't know what they're getting into. They may be super well intentioned. They envision this beautiful pregnancy and process, but they don't really know what
Hmm.
the pregnancy will be like. No one ever knows for sure how the pregnancy
Right.
will go, but they have no idea really what they're getting themselves into. I think as a mental health professional, you would agree that it complicates the issue of the transfer of custody from the carrier to the intended parents at birth when someone has never had a child themselves and hasn't already kind of processed that information. Lisa, once we've gone through the history and the gestational carrier seems like an appropriate candidate to be a carrier, then we would want to proceed with a uterine evaluation, and we would do an office hysteroscopy and a saline infusion sonogram, and we actually check, the endometrial layer with the hysteroscope, looking at it directly with the camera. The saline infusion, we're able to see the myometrium to make sure it looks normal, and to check the fallopian tubes to make sure that they're not collecting fluid or any other factors that might decrease the chance for a successful embryo transfer in pregnancy. And we do a
Fantastic.
child transfer to make sure those things. And once we've done all of that, then we usually have the couple and the carrier, or the individual and the carrier, move on to the legal process. That's usually the order that I think makes the most sense from a process and a financial kind of perspective moving forward with them.
That's fantastic. Can we just go back to doing a prep cycle? So, some people ask about that. They say, well, is that really necessary that my doctor has to see like how the uterus is working in vivo? Is that important? Is it not important? Can you talk a little bit about that?
Yeah, and that's a good question. I don't always do that, Lisa. It depends on the carrier, because sometimes
Hmm.
if they come in for the saline infusion and they have a beautiful 8 millimeter lining, I know that they're going to do just fine. If
Hmm.
there's some question during the uterine evaluation of the endometrial layer, then I do recommend that prep cycle to
Yeah,
make sure
make
that
sure.
they are indeed a good candidate to move forward. And I recently had a couple go through. They're extremely sweet. The woman had stage 3 breast cancer in her early 30s. She had frozen embryos, and we had a successful first baby, and they were thrilled. They had one embryo remaining and were very anxious to go through again. And they brought a lovely carrier, but her uterus, the lining did not look good. And she had recently had a baby. We did all kinds of evaluations and treatments with antibiotics and probiotics, and of polyp removal. And for her own health, she needed to keep pursuing that. And that's an aside. But I finally just had to say, I just don't think she's the right candidate at this time. And we did move on. And it's hard because, as you said, she was otherwise a wonderful candidate. And it was hard.
Yes.
But luckily, we moved on to another carrier who's also great, and she's currently, just entering her second trimester. So I understand. I think many of us in the IVF world have been patients ourselves and have been through these processes. It can be devastating when you think you're about to move forward and there's a setback. But I always try to, remind the patients that we're doing it to maximize our chance for success. And this couple had one
Yes.
embryo remaining and no chance of getting another one that would be, genetically related to the mother. So it's just, that can be very hard, but I think that's very important for people to understand that as medical providers, we are trying to make sure we're not trying to be roadblocks. We're trying to make sure they have the best chance for success.
Absolutely. That's so important. And I think it's hard. It is hard for people. And it's important for people to, I think, for everyone out there to think about that because it's natural to want to fall in love with your gestational carrier the minute you meet them in your match meeting or even your egg donor the minute you meet them. But it's better just to kind of keep your heart in check a little bit until everything is checked out. The psychological screening, the medical screening, everything's done because you never know.
Right.
And how do you feel about this idea where a lot of people talk about, well, my gestational carrier is a little bit older, maybe she's, 40 years old, and so why can't I just get pregnant with my own eggs at 40 years old? Why is this such an issue? If the carrier can have a baby at 40, why can't somebody else have a baby at 40?
Lisa, that's such a good question. And it's an issue that we still deal with. And the educational process is really important. And it's still hard if you're not doing this day in and day out, like we are, to understand that unfortunately for women, our biology is such that egg quality declines with age, and it declines significantly. And all women are a little different.
Hmm.
All women in the reproductive window are on a downward decline of their egg quality and their egg number. And everyone may be a little different. There's some 40-year-olds that have better fertility than others. But yeah, the eggs are really the determinants of the quality of the embryo, the majority. I mean, the sperm do contribute as well, but the age of the egg and all the things that we look at, AMH, FSH, antral follicle count, all the studies show that for better or worse, age is still the best predictor of how those eggs and embryos will perform in producing live, healthy babies. And so that's it's paramount in this process that the egg quality and the age is important. And so for a carrier, age does affect the uterus eventually, but the data would show that age doesn't start to really play a role until after 40. After 45, we see in donor egg cycles that the pregnancy rates do decline some. It doesn't mean it's impossible. That we have many patients over 45 carrying pregnancies, whether they were conceived with their eggs that were embryos that were created at a younger age or with donor eggs. It can still happen, but the success rate is lower. And so that is still true with carriers, but certainly a carrier, I usually try to have carriers less than 40 or 42 because the risk for fibroids and adenomyosis increase. But if you get a carrier who's very healthy, normal weight, and does not have fibroids or adenomyosis, the early 40s, it's possible, but they would have to be exceptionally healthy and have a really healthy uterus as well.
So basically, people really have to kind of think about pregnancy in these two parts. It's the egg, but also the uterus. And your eggs do get older with time, but the uterus stays intact and healthy for a longer period of time. And so someone can be a gestational carrier, and that person may not be able to use their eggs, right?
Correct. Yeah. When we're doing the IVF process and using a carrier, we're separating those two things. Yes.
If you're not familiar with Gago Fertility, you need to check them out. Their website is gagofertility.com, and they are a full service practice. It's a female led practice with multiple offices in Michigan, and they offer IUI, IVF, donor conception, and surrogacy because Michigan is going to be a surrogacy friendly state very soon. So you can get any service you need. And what's really special about them is they really believe in educating their patients. They give you so much education and will tell you about things that you just don't know. I know that was really important to me when I was going through fertility treatment. I really didn't know anything and I needed a hand to hold and someone to educate me. And that's what they will do for you. So check them out, gagofertility.com. Ask them any question you like, and they will be happy to serve you. I was actually looking today on the CDC website and I saw that seems to be an increase in people freezing embryos ahead of time. Are you seeing that in your practice also?
Yes, absolutely. It's a big trend, and it's been an issue with SART, the Society for Assisted Reproductive Technology, where we keep track of pregnancy rates because the way they do it right now, it's in flux. It's going to take effect, but as you know, because the success rates, when you look at SART success rates, they lag behind reality. They're making changes now, which is great. But embryo banking or embryo accumulation, both of those terms are used, is increasing because before we used embryo banking more for cancer patients and things like that. But more and more women are understanding, women and couples, that the issue with egg quality with aging. And so if we're seeing them, even when they're 30 or 32 or even 35, they might say, we're going to do an IVF cycle now. And especially the 35 to 38-year-olds, particularly, I say, by the time you have this first baby, breastfeed the baby or whatever, have this, spacing of your children that you'd love, you may be 38 or 39 when you're ready to try again. And you're already
Mhm.
having trouble when you're 35. So we encourage those women to do several cycles and bank embryos. And we kind of, I don't know what other practitioners or whether other IVF physicians tell their patients. I generally think, 2 to 3 chromosomally normal embryos per desired live birth is a very generous cushion, but it's a nice target. Some 39-year-olds are not going to be able to achieve that, but that's kind of a ballpark idea that we talk about.
That's wonderful. And I think it's, so forward thinking because people don't think about it. They just are thinking about how can I get pregnant now? And they're not thinking, well, what's going to happen in a couple of years when I want baby number two?
Doing this and going through my own reproductive, life cycle and all that, I came up with a talk, and I have a slide that I love. It's not very popular with women because of the reality stinks, right?
Yeah.
But I
Yes.
laid out a timeline, right? And I said, maybe our reproductive age starts at, biologically 13 to, 43. But socially, nobody wants 13-year-olds to have babies. So then you push it up and you say, okay, in our culture, maybe even, 15, 20 years ago, we take it to 25 to 40, right? Then you narrow that down. Now you have this small window. And then most women now are not even thinking at 25 to have a baby with our current culture. Then you slide that up to 32 to 35. And now you have 35 to 40. You have this narrow window where
Hmm.
the average women that we're seeing are trying to have babies. And maybe it's 28 to 40, but that's still, if you think of, if you have a miscarriage, if you're traveling for work, or if you have, your parents are ill, or any kind of bumps in the road, that window suddenly gets very small. So I think banking embryos and giving yourself more options is really helpful. And I think I do like that timeline and showing people kind of just
Yeah.
everyone. And I think partly when doctors, we always, it's not funny, but we delay our financial career as far as our 401k and all those kind of things until after you finish your training often. And we're much older. So we start seeing a financial counselor. And I think that all women and couples should do, but the financial counselor, right, lays out your years remaining and how much you need to save. And so I think that's how the concept was kind of born, because I think it would be nice if all women had the opportunity to say, I'm 22. What do I want? How many children would I like to have?
Mm.
How far apart would I like them to be? And start mapping that out into that small window. When you
Yes.
finish your master's degree and when you get married. And, sometimes the guys are like, well, I'd like to be married for 3 years before you start trying. I'm like, she's
Yeah.
36. You can't wait 3 years. But the men are more open to the idea of well, maybe we could make some embryos and bank them now and compromise and wait for a year or 18 months. So sometimes I feel like I'm a little bit of a marriage counselor, which I think most IVF physicians are, but helping couples kind of talk through that process can be helpful.
Well, that's so fantastic because I think it's so hard to think ahead in that way. And lots of times doctors are not thinking about that, right? They're just looking at the patient's urgency and their fear and their anxiety about getting pregnant right that moment. And also I see this happen with lesbian couples a lot, right? They're coming in for baby number one and they're not thinking about, well, what about baby number two with the second partner?
Yeah, no, and I have that conversation and talking about, saving, getting extra sperm. So you have, if it's important you to have the same sperm donor the second time, to make sure that you have some extra sperm set aside so that that can happen. And how many kids do they think they might want to have?
Yeah, and people don't realize the sperm sell out. This
Right.
is really just the world that we're living in, unfortunately.
And it's been a nice trend in our state also that more and more couples and more individuals have coverage for egg freezing and embryo banking and infertility treatment in general, so that we can have those conversations and talk about that big concept of family building and how does your timeline look, and ideally how would we like this to go?
That's amazing. I think that's wonderful. It's so helpful to have those conversations. How do you manage with the people who are, let's say, out of state or out of the country, or maybe coming to you for surrogacy because they have a medical condition and they have to plan ahead. Are you able to manage some of this over Zoom or some of the consultations?
Yeah, we do a lot of visits virtually, and even our local couples, more and more people are coming in person again after COVID. But yeah, I think a lot of practices, including us, we were fortunately already kind of starting to be up on a platform for virtual visits for convenience, because it's much nicer, Lisa, to not have to make both partners come in. They may be in different places, and we can all three sit down and have a conversation like this and talk about issues. And I think the convenience, but also the inclusiveness of it, to be able to include the both partners in the discussions, it has been really nice and an added thing. I think we started it before COVID, but I think COVID ramped it up quickly because it was the only way to provide care. But yeah, it does open up the entire world for conversations. We've had virtual visits with egg donors from, even overseas, and things like sometimes it's a related egg donor, and we can have those visits, and it's helpful. It helps facilitate.
Let's say because I hear this a lot in a gestational carrier journey, somebody's coming in from out of state or out of the country, and they say, well, how is this going to work? How many times do I have to come into the clinic? What is that going to look like for me?
Somewhat depends. If I had my preference, I like to meet the carrier in person one time prior to the embryo transfer. So we usually try to have the initial consultation virtually to go through kind of the history and the questions and make sure that they seem like they're a good candidate. If it's feasible, then I do like to bring the carrier to my office at least once so that I can have a face-to-face conversation with them, do a physical exam, do the uterine evaluation myself, and go through the consent forms together, although we can also do consents virtually. If it's a really big hardship for that to happen, and I can identify a reproductive endocrinologist and infertility specialist closer to them, then sometimes we'll do that. I mean, I have colleagues all over the country. So that is helpful when we do that for each other, is evaluate the carriers to save money for the couples if the travel is a burden. And then they would need to come for the transfer, of course. Frequently, the monitoring of the uterus and the lining is done remotely. We try to identify another fertility clinic, and I do it for other people all the time. And the courtesy is extended to my patients as well.
And do they maintain their embryos? Do they keep their embryos at your facility, or how do they decide that?
Yeah, usually we do that. I mean, the embryos can move. And because of the previous laws in Michigan, some couples weren't comfortable. Sometimes we did the transfers in Michigan, and then the carrier resided and delivered the baby in another state. Sometimes couples would move the embryos to the state where the carrier lived to do the transfer.
So now that the laws have changed a little bit, what would you recommend?
I mean, I think it's best when there are experts that move embryos all the time. In the great majority of the cases, it goes fine. But I guess my preference, having had, embryos myself in the past, is if the less you can mess with them and move them around, probably the better. So ideally, the carrier would come to where the embryos are. But sometimes that's very difficult. And instead of bringing the carrier, we move the embryos to facilitate the cycle.
And what about when you're in a situation where the patient's like frozen eggs or frozen embryos ahead of time? Do you move them to your facility?
Yeah, we definitely do that. It just depends on the whole scenario, where the couple's living, where the embryos are, and where the carrier is. Because the couple, in a perfect world, I'd love to have the couple present during the transfer so that they can be part of a very important event in their child's life. I have 6 children.
Oh my goodness.
Yeah, so I tell them it's a job hazard.
It's amazing.
I did have a serious complication during a pregnancy in which, unfortunately, I lost the baby in the second trimester. It was very hard, but thank you. Many good things have come from that experience. So it was a very hard thing. And as much as I'd been involved with pregnancy loss many times, you can never estimate how devastating it is.
So devastating.
Yeah. So I did go through the carrier process. My gestational carrier was in Florida because I chose not to take a chance with Michigan laws. And I have a very close friend and colleague in Florida who helped me with the process. But I love that I can tell my daughters that I was there. I saw them when they were blastocysts,
Mm.
and I was present. I was there during the transfer, and that I was part of their conception in a non-traditional way, but I was there and very much, it was such a big and important day. And I would go to Florida. I am fortunate to have the professional and the financial resources. I was able to go to Florida for their ultrasounds and go down after immediately. She actually had sudden delivery, but I was able to get there quickly after they were born.
Oh, that's
So,
wonderful.
but it'll be really nice that, if I would have been able to use a carrier in Michigan, I would have been able to be present for the delivery. But because I had to travel, that didn't work out. But
Right.
I have healthy children and the carrier's healthy. So that's the most important thing.
And ultimately, it is really the most important thing for everyone, right? And
Right.
and so it's understandable that people want to move forward and just use someone who's their friend for an egg donor or a surrogate or somebody they found on the internet, and they think, what's the problem? Ultimately, everybody wants a healthy baby, and
Right.
and that's the most important thing.
It really is. And it's important that the patients try, and I know it's hard, but to trust and understand that their physicians have seen a lot of things
Yes.
and we've seen the bad things that can happen, and we're trying to help them avoid those things and get them to the healthy babies, healthy carrier, happy parents situation. And that's the ultimate goal for everyone.
Yes, absolutely. Speaking of which, I think, while we're on the subject of surrogacy, a lot of people don't know why there has been kind of a change in the last decade from twin pregnancies to singleton pregnancies, both in gestational carrier cases, but also in IVF cases. Maybe you can share that with people out there because I think people are not familiar with that.
I know, and there are several of us with that situation that we are professionals. And it was a big decision, but now we know the data is very strong. We know that singleton pregnancies are safer for the babies and for the person carrying the pregnancy. So we very strongly advocate for single embryo transfers because complications are lower. And it is a really important factor. And the data has accumulated. And I think, again, with had there been a situation where I wasn't having to be traveling out of state and doing those kind of things, I might have leaned in more that way. And we talk to patients still, though, about that the information is much stronger now. And the more I do single embryo transfer, we know the data bears it out that there are lower risks for those pregnancies. And that's why we do it. And twins are fabulous in a lot of ways, but if you knew someone would deliver full term healthy babies, but we don't. And we do know that there are risks. And that is the hard part, is that the bad situations where the babies are born at 23 or 24 weeks and they're peri-viable and they may end up with lifelong health issues. And that the woman carrying the pregnancy may also have significant health issues. Those are significant factors that we talk about.
I understand that's so hard for some people who may be going through so much to try to have a baby and spending so much money on a gestational carrier journey. And they say, well, I can complete my family if I had, triplets all at the same time. But they don't realize how dangerous it is. And, we only see pictures online of the healthy babies and the pretty stories. And there are many that are not.
Exactly. Exactly. And that's what I tell people. I mean, as a resident, I think I delivered, triplets that all died numerous times.
Mm.
And there are happy triplet stories, of course, and even twins. Twins can have complications. So we've gotten much better with IVF. Also, pregnancy rate, the live birth rate per single embryo transfer has also continued to improve with different techniques and things that we have. So that's another benefit.
Yes, that's a huge benefit because back then, when they were putting in 2 or 3 or 4 embryos, the chances of success were so low. But now the success rates, particularly with a gestational carrier, are so high, right?
Right.
That's so important to know. And I think for people, it's certainly a tough decision to make. And if they don't have the resources to go through 2 gestational carrier journeys, it might be a decision to make whether or not they can have 1 child and not 2. But ultimately to have these lifelong complications is life-changing.
It is. It is
Yeah.
for everyone involved. Yeah. And very expensive. And even taking care of multiples who are even if healthy, it's people say, well, it'd be cheaper to just do one transfer. But the cost of twins is tremendous, and paying for, childcare and all those kind of things for two infants at the same time is way more expensive. Someone did that calculation. It's in one of the journals somewhere, and
Oh, really?
yeah.
I'm sure it's much more expensive. Yes, it's really difficult. Well, I think all of these things are so helpful for everyone to know. So thank you so much for helping us understand some of these details that, people in our industry talk about, but I think are really hard to tease out for most patients. And when you're anxious and you're going through treatment and you just want to get pregnant and have a baby right away, it's really hard to think through some of these details. So thank you so much for making it clear for us. And is there anything else you feel like people should really know about this process or about surrogacy?
I think it was very disappointing to hear the Pope statement about gestational
Yes.
carriers, because I think, like, I don't want my children to see that and to feel, I just think it's just so unfair. And there was one of the Republican senators in Michigan said, oh, children are a gift and you can't do this. And it's just, that's really unfair to do this, because this is a medical process. We're treating medical issues for people. That's such a slippery slope, because we very much believe that reproductive health is essential. It's essential healthcare. This is an essential process. And we started that slogan during COVID of reproductive healthcare is essential. And I think it also goes into women's rights and the ability of a woman to make decisions for herself about her body. And I think those, I feel so strongly. And as the more I go through this life and my career, I think those things are so important for people to understand, that our country is about individual choices. We're so adamant about our freedoms, and I think I fully embrace that. But this is the thing, is that I want to make it possible for people to do the things that they choose are right for themselves. And if this isn't the right process for someone, that's fine. There are lots of other ways that they can proceed in their journey. But for some people, this is the only way that they can see forward for their family building. And there is nothing in my mind evil or bad about wanting a family. And I think that God knows that in my eyes. And I laugh that, the Holy Family involved a third party.
Hmm.
And
Hmm.
I just think that it's
That's
very,
true.
and I definitely feel like when I'm doing an embryo transfer, I feel this, it's amazing. And we put embryos in the uterus all the time. I can't give life. I can only be an instrument of helping, and something much bigger than me allows that life to proceed.
Yes, absolutely. 100%. And also, I think it's important just to highlight that we know, working with surrogacy journeys for, many years, that these are women who really want to help, and that the rules that we live by through the law and also our American Society for Reproductive Medicine guidelines do instruct us how to really take care of these women. So this is not like a third world country where these women are objectified or treated poorly and there's no sex trafficking here. This is the United States where we really abide by these rules. And if you're using a good reproductive endocrinologist, they will follow those rules as well. And you can feel sure that your gestational care is going to be taken good care of. And this is going to be a wonderful experience for her. It's something that she loves to do and makes her very happy.
Absolutely. Absolutely. I agree with that on so many levels. And I think there's also, like, I feel very much, I also take care of egg donors, right?
Mm-hmm.
They're giving a very precious gift. I feel very responsible for their health and taking good care of them. And the same with the gestational carriers. They're providing a tremendous gift to the intended parent or parents. And I think we all really work hard to keep them safe and give that. And I do think that they deserve to be compensated. It's the same thing with egg donors. It's a mix. And I know you're aware of the studies that show that it's a mix of altruism, but also
Mm-hmm.
they deserve just compensation for their time. And people who advocate otherwise, like, it's another way of diminishing women. Why? I mean,
Yes.
women, they're putting their life at risk in a
Yes.
small way. it's their time and their energy, and they deserve to be compensated just like we would do for other things. So yeah, it's actually a wonderful mix of altruism, but also that's a way of giving back to them for their beautiful gift, is just to provide for their needs during the time of the pregnancy.
Absolutely. Absolutely. I agree 100%. I think that that's so well said. So if anyone has any questions about this, please feel free to reach out to Dr. Gago. Where can people reach you?
Thank you, Lisa. So our website, gagofertility.com, has several different avenues to reach out to us and our team. And we'd be happy to schedule a visit to discuss further their individual situation and see what is the optimal plan for them moving forward. My team is fabulous. They're well known throughout the area for their compassion and our good work together. And I love working with my team.
And I can attest to that because I know some of the people on your team. They're lovely people. So if you reach out to Dr. Gago on her website, you'll be able to reach out to those wonderful people and get your questions answered and meet some wonderful practitioners. So thank you so much for meeting us today and for highlighting all these wonderful and really important issues to discuss in surrogacy, but also in fertility treatment in general. I really appreciate you coming in today.
Thank you, Lisa. Thank you for having me.
And for all of you out there, thank you so much for joining us. And if you like this episode, please press subscribe because that's how we keep going. And please also come to our website, familybuilding.net, because we have lots of information there as well. And I look forward to seeing you next time. Hi, it's Lisa Schumann. I hope that you enjoyed that video and I hope it helped you. And if it did, please give us a thumbs up and subscribe because that's how we keep going. It's really important to us. And if you liked it, you might like this one.